Intersectionality is the way that factors such as race, class, gender, disability, and sexuality intersect to shape each other within broader structures and processes of power. The concept of intersectionality emerged in the 1980s USA by the Combahee River Collective, a group of Black feminist lesbians. They thought that Western feminism represented them as poor, uneducated, and they felt that their voice wasn't being heard. As a result, they developed frameworks to increase their representation and address these unfair perceptions of them with the aim of broadening feminism. In 1989, Kimberly Crenshaw termed the concept of intersectionality as a progression of the previous frameworks. This was done with the aim of addressing how gender intersects with drivers of inequality and social determinants of health, such as age, class, ethnicity, disability, religion, and sexuality. Crenshaw believes that intersectionality brings awareness to the many constituents within groups that influence a person's identity and their relationship to power.
So, why do we need intersectionality in general? This perspective focuses on interlocking systems of oppression and the need to work towards structural changes to promote social justice and equity. An intersectional perspective can guide a shift in policy and practice that brings social factors to the foreground in order to establish and facilitate healthcare and reject drug policies that punish people of minority and low economic status. Why do we need intersectionality in drug policy reform? Despite the significant burden associated with substance use disorders, especially among persons who inject drugs, most affected individuals do not engage with any type of formal or informal treatment. Addiction stigma, which is represented by negative social attitudes towards individuals who use alcohol and/or other drugs, is one of the barriers to care that is poorly understood. Addiction stigma is conceptualized as the endorsement of negative stereotypes by members of the general public towards individuals coping with substance use disorders, including persons who inject drugs, thereby increasing marginalization and discriminatory behavior directed at the stigmatized group. Addiction stigma is thought to exacerbate both structural and individual level barriers to treatment and help seeking. On the structural level, beliefs that individuals coping with substance use disorders deserve to be punished rather than helped are related to lower support for public health-oriented drug control policies among the general public. Recent studies on intersecting identities and substance use disorders have found a significant three-way interaction among sexual orientation, gender, and race. Sexual minorities had a greater risk of self-reported lifetime substance use problems than heterosexuals, with nuanced gender and racial differences. Of greatest note, sexual minority women of color had greater risk of substance use disorders than heterosexual women of color and than white sexual minority women. So, how can we change individually? In order to do this, we must reflect on our own social position, values, and experiences, and consider the impact that this may have on patients. Acknowledging our own unconscious bias can increase our awareness of how inequities are produced. In order to apply intersectionality to the use of drugs and motherhood, I'll give the following example. Given the severe social stigma surrounding mothering and drug use, research has shown that children of minority and low socioeconomic groups were more likely to be assessed as being at risk and more likely to be removed from their homes than those of higher socioeconomic status. Thus, the threat of removal of children from their care is more pervasive and substantial for these mothers and discourages them from accessing social and health services. Furthermore, the discourse of bad motherhood is grounded in identification of poverty with individual failure. Its association with race and class ideologies have also played a pivotal role in limiting public policies, medical practices, social services, and benefits for mothers living in poverty. And social marginalization exacerbates their stress and limits their access to social and healthcare. So, how could intersectionality help in this case? It could improve access to healthcare by reducing financial barriers to care for women. It could offer expanded coverage of behavioral healthcare related to treatment for mental illness and/or illicit substance use. And it could provide a holistic intervention that recognizes that children could constitute a vital resource of support in the struggle with psychological and symbolic aspects of poverty, especially for women of color, and it may be an important step towards this. Thank you.